This is Tim, your Block 2 lecture instructor, and this module is going to cover the cardiac system. As I've done in the last PowerPoint voiceover, I'm going to go over a series of slides, point out pages in the book that I think are important, whether it be for the test or just for your own general knowledge. I'll also point out a lot of boxes that are going to help concrete some of the information that we're going over. You'll also find that there was a couple things that I've added to these slides that were not there in the PowerPoint that I posted online yesterday. They're not major things, they're slight variations, and again, they're really things that I kind of found as I went over the PowerPoint again and as I went over my own notes just to help concrete some things. So like I said, I'll point all this stuff out to you. All right, so for this PowerPoint, the first couple slides is going to be based on angina, and then after that we're going to go over the myocardial infarction. So for the next roughly 10 slides, it's really going to be a comparison of the two. So for angina, it's something that's very sudden, and usually it's a response to exertion, whether you're outside mowing the grass or whether you're mopping the floor or picking up the kids, or it could be a response to emotions, whether you're happy or sad or anxiety. It's something that's triggering a psychological response is what's causing the angina to happen. Also, extreme temperatures can also be a effect for angina. That's really due to the fact that, as we mentioned before, when someone's very cold, their body is actually trying to conserve as much heat as it possibly can by trying to pull the blood into the core system, keeping it nice and warm so it keeps all the vital organs to be warm. And with that can cause a lot of capillaries and a lot of very small vessels to constrict. And again, the heart itself has coronary arteries that are very, very, very small. And so with extreme temperatures, that can also have an effect on it. So one thing I did add to this voiceover that was not on the PowerPoint is this link. This actually takes you to, I think, roughly the American Heart Association. It's a very easy read. It talks a lot about angina as far as what the symptoms are, what interventions that should be done as far as testing and to actually help your patients that have it. So also, another thing that's with angina is the quality and the severity. With angina, you're actually going to have a squeezing vice-like pain. It almost feels like someone's actually taking their hand around your heart and actually just squeezing it. And that's actually very different from myocardial infarction, which we'll find out later. So again, this is more based on how it feels. Like I said, it's that squeezing vice-like pain. The location and the radiation for angina usually is substernal. It may spread across the chest and actually to the back and down the arms. This is actually, again, quite different from myocardial infarction because with myocardial infarction, it's actually a substernal pain, but it spreads across the chest, down the arms, and also up the neck. So that's a big difference between the two. For the duration and the relieving factors, angina is usually the left side of the chest without radiation. It usually lasts for about 15 minutes, and it's relieved by rest. That's the big difference between angina and myocardial infarction is that, again, your angina is based on exertion. So if you are mowing the grass and you start having this chest pain, that's squeezing and vice-like, and you actually sit down and relax and just try to cool down a little bit and actually catch your breath, you'll find that the pain is actually going to go away based on the fact that you're resting. Other things that could actually cause the pain to go away is nitrates, like nitroglycerin pills. Those are sublingual, you put them on your tongue. Nitrates actually are vasodilators, so it actually takes the blood vessel and makes it as big as it possibly can, so it can actually get more oxygenated blood to that muscle. Oxygenation therapy also works just because if you're giving your patient some oxygen, it's going to make the blood vessels, not so much the oxygen does not make it dilate, but the oxygen itself will enrich in the blood stream and actually cause the heart to beat a little bit more efficiently, again, with the amount of oxygen that you're giving your patient. So let's see here. Let's see if there's actually anything that I missed. As I went over the paper that I printed out from the website, there were a couple things that were kind of interesting. Let's see here. We talked about the 4 different types of angina. The risk factors for actually having angina is cholesterol levels, high blood pressure, smoking, diabetes, being overweight or obese. Let's see here, inactivity, unhealthy diet, age has a big factor in it, and also family history. One thing that was actually added that I found in this website was that, and what I thought was very interesting is that according to the website, angina is actually a symptom of something else. So you may not necessarily have a myocardial infarction or a heart attack right now, but this symptom of angina and the squeezing vice-like pain could be a symptom of what could be a myocardial infarction down the road. So the blood vessels themselves are either spasming, or there's something that's just slightly occluding it enough that is causing the pain, but not necessarily occluding the blood supply and actually causing some sort of ischemic attack. So I thought that was very interesting. People live with angina all the time. Sometimes they take medication for it to help with this symptom. And then the doctors don't really find out anything other than that, or nothing that needs to be fixed right now. So speaking of which, things that your doctors may actually do to determine or to rule out that you're actually having a myocardial infarction or a heart attack is they could do an EKG, they could do a stress test, blood test, chest x-rays, let's see here, a cardiac cath, which we'll talk about later, and a CT angiography. So those are some things that your doctors can do in order to help rule out the fact that there's now something more than just a simple angina attack. Treatment that could also be lifestyle changes, your patient losing weight, controlling their diabetes, stop smoking. They can take pain, or blood pressure or cardiac medications. Let's see here, and I think that's about it. Yeah, those are the big things. So anyways, look at the website. Like I said, kind of familiarize yourself with angina as far as what the symptoms are, what they can do to actually diagnose that it truly is angina and not something bigger. And I think there might be a couple of links to medications, which we're going to go over in class 2. So, all right, so myocardial infarction. This is an actual diagnosis. This is something actually going wrong. This is where the blood vessels are constricting or occluded to the point where your heart is not getting enough oxygen, and it's becoming ischemic. It's I wouldn't say necessarily killing the heart, but it's causing the heart not to have enough blood supply or oxygen, nutrients, and it's actually causing some damage. So with the myocardial infarction, this could be sudden. This is you're laying on the couch watching TV, you're up and walking around, you're playing with the kids, you're mopping, you're mowing the lawn, or you're, resting and doing absolutely nothing, and you still have this disease, this actual event. This could be without precipitating factors. This says here in the PowerPoint, and for whatever reason, it says it's often early in the morning, and the website even said that too, so not quite sure why. But the link that I've actually posted here is for the Cleveland Clinic, and it's an acute myocardial infarction. It's a little lengthy. It's not going to take you a real long time to read it, but I thought it was very interesting as far as telling you what it is, signs and symptoms, interventions, and outcomes and stuff. I thought it was everything I keep telling you as far as how you should be studying. So definitely check out the website. All right, so let's see here. With myocardial infarction, you've got quality and severity, which is an intense stabbing, vice-like pain. Whereas with the angina, that was actually more of the squeeze-like, vice-like pain. The myocardial infarction is actually the stabbing, and I think it's because of that ischemic area that's not getting enough blood supply, enough oxygen, enough nutrients. It's actually causing that stabbing, and I've been told that it feels like people are stabbing you in the chest. So that's one of the big differences between the two. They also felt a big intense pressure, and they felt that it really was, that overwhelmingly sense of, okay, it's not just a matter of I got this little chest pain, I can live through it. It's severe, and they really felt like they were going to die, or there was something majorly wrong that took them to the emergency room. So. The location of the radiation, again, it's substernal. It may spread throughout the interior chest to the arms, jaw, neck, and back, whereas the angina is more of the substernal arms and chest areas. So again, the difference between the two is that jaw area. The duration can be continuous, or some people have no chest pain at all. It can be relieved by morphine, because morphine is actually a vasodilator. It can be relieved by cardiac drugs such as nitrates. It also can be also relieved by oxygen therapy, because again, even though you're having some sort of ischemic area, you want to try to get as much blood that's full of oxygen as you possibly can. Something's better than nothing, and you try to do what you can. I don't think I put this in the PowerPoint, but I think they do mention on the actual website. But I learned in school MONA, which is morphine, oxygen, nitrates, and aspirin. Because aspirin being I believe what I put down here, aspirin is an antiplatelet, so it's going to keep the plates from sticking together, and again, that's really what the ischemic attack is from some sort of plaque buildup and actually causing some sort of tear, and that tear is the clot, and that clotting can be busted, at least not so much busted, that's the wrong word. It can actually be it can make the problem less worse if the aspirin is actually in play. And I've been told if you actually chew on the aspirins, within a 2-hour period, it could relieve some of the actual pain and discomfort, and actually do some good and for the MI. So MONA, good thing. All right, so for chapter 35, let's see here, cardiac changes associated with age. So 692. That page real quick. All right, so 692, box 35-1. So changes in the cardiovascular system related to age. I thought this was important because I think that as you continue with your nursing career, you're going to take care of a lot of elderly patients, and based on age, you can kind of find out where you're starting from as far as whether it be education or problems or things you need to actually do to fix. So with age, cardiac valves tend to wear out. The conduction system isn't as efficient as it was. Left ventricle, which we'll find out later in the PowerPoint, the congestive heart failure has a lot to do with it. And then the actual arteries themselves. With age comes a lot of problems as far as whether it be high blood pressure or your heart isn't working as well as it used to. Your kidneys aren't as efficient as they used to. There's a lot of multi-system organ problems that aren't necessarily disease processes, but the fact that you're getting older and changes some things. So on 693, 35-2, the Gordon's functional health pattern, I think this is also important because when you're admitting your patients, you're learning for the first time all about them, and if you don't ask the right question, you don't get the right answer. So I thought this was important for you to kind of learn kind of the tricks of the trade, if you want to say it, as far as like I said, asking the right questions, getting the right answers, finding out more about them or as much as you possibly can. It helps determine where you're going to start with either education, medications. It just helps you be able to take care of them a little bit better. So definitely check out those 2 pages in those 2 big boxes. So. All right, so for cardiovascular disease, there are several things that can contribute to this. There are non-modifiable traits, and there's modifiable traits. So for non-modifiable, let's just say me being 41 years old, let's say I had something cardiovascular problem that may be attributing to age, gender, my ethnic background, or family history. Those are things that I can't take care of. I can't change those things. So if I have cardiovascular disease, it's because of something that's in me genetically that I just couldn't change, and it just predisposes me to actually having disease. To modifiable, we have lifestyle change, lifestyle habits, whether it be eating too much or not eating the right foods or not being nutritious or, smoking, not going to the gym, being lazy, watching too much TV. Those are things that I actually could change and actually make better so I'm not having major cardiovascular problems. Again, physical activity, we've got the obesity, and there's also psychological. Being stressful, having anger issues and depression tend to also cause metabolic problems that can lead to cardiovascular disease. So for your assessment, you're going to do a patient history, which again, like I said, if you're on 693, that Gordon's functional health pattern that kind of tells you where you're at and where you need to be. You have a nutritional history, we got family history, current health problems, functional history, what works, what doesn't work, and you also have your physical assessment. So you're going to assess their general appearance on a whole. Do they look healthy? Do they look tired? Do they look like they're fed well? I mean, do they look like they're exercising? I've taken care of patients who are in their 90s that look like they're in their 50s. Whether it be that being genetic or them just living a good lifestyle and actually keeping themselves healthy and happy, and that kind of helps. Like I said, just that physical assessment tells you a lot. Let's see here. Other assessments, you're going to look at labs. So on 702, there is a lab profile in 35-3. So these are the things I definitely need you to know. So we've got the creatinine kinase, which is the CK. We also have, let's see here, the serum lipids, which is your cholesterol, triglycerides, plasma density. I need you to know those things, and then the serum markers. We have the troponins and the myoglobin. So when your patient comes in and is having chest pain and you need to rule out whether it's angina or a myocardial infarction, there's going to be blood tests that they draw, and as those blood tests increase, it will tell you whether or not there's a difference. So let's say 80-year-old patient comes in and he was mowing the lawn and he started having chest pain. He comes to the hospital, start doing some blood work, and you find out that his CK and his troponins are high. As they increase over a roughly 6 to 8 hour period, it's going to tell you whether or not it's truly a heart attack or if it was just angina. So if the markers are low, then it's had angina. It's just stress related or physical activity related. If they increasingly get high over every 8 hour or every 6 hour draw, it's going to be indicative of actually having a heart attack. So definitely learn that box as far as the lab values and what those lab values actually mean and why we're drawing them. For diagnostic testing, we can do a cardiac cath, which they go through the femoral vein and into, or femoral artery and go all the way up into the heart and actually look at those coronary vessels and determine if there is some sort of blockage. They'll do an EKG. That EKG strip, which you'll go over later in this PowerPoint, if it was normal and there's some sort of change, that will also be indicative of actually having a coronary problem, whether it be a heart attack or something else. They can do EP studies. They can do a stress test to find out if the heart's actually beating correctly. You can do an echo, which is like a 3D imaging of the heart, and find out if the ventricles and the atriums and the valves are working correctly. You can do a TEE, which is a transesophageal echocardiogram, which is actually looking at the heart from the backside through your esophagus, or they can do an MRI. So, moving on to chapter 36. Let's see here. Let's start with 713. All right, so for your ECG, or as we know as the EKG, I want you to go to 713 and 36-2, and that page itself is actually the lead system. It tells you where to place the leads. It tells you which lead is actually looking at what as far as the electrical conduction system of the actual heart. So understand what each lead means, because based on the lead placement and the rhythm change will determine exactly what's going on with the heart, whether it be an MI, whether it was a past MI, or possibly one coming up, or if there's something in the electrical system that's just not connecting the way it should. So, and I'll explain to you why later. Also, let's see here, continuous electromonitoring system. We have telepacks and Holter monitors. So for those of you who've been in the hospitals doing your clinicals and actually taking care of patients on the med-surg floors, sometimes they'll have a little monitor pack that's hanging around their neck or usually tucked into their gown pocket. That's actually attached to their chest, which is being monitored by somebody else within the hospital, and they're staring at their heart rhythm to see if there's any changes from what they came in with. Because always look at the baseline. So grandpa may come in with normal sinus rhythm, he may come in with sinus tach, he may come in with sinus Brady, he may come in with AFib, but someone's staring at those baselines to find out if there's actually a change due to what we're giving them, or just a physiological change itself. So, so that's what those do. All right, so let's see here, page 716, 36-5. Right, so this is your, this is a heartbeat. What I want you to do is I want you to understand the concept of the P waves, the PR segment, the PR interval, the QRS complex. Let's see here. I also think that this ST segment and the T wave are very important for you to understand, because, like I said, if you look at the rhythm strip on 717 36-6, that's actually your heartbeat, and each one of those blips is the actual heart contracting and relaxing each time. So if you can recognize what's normal, whether it be sinus rhythm, and you see a change in whether it be the P wave, the QRS complex, or the actual T wave, you can kind of see what's going on with your patient as far as how the electrical system is working. So I need you to understand those because later on, as we do the rhythm strips and you listen to the other videos that I posted from YouTube, then it'll make a lot more sense. So, and this is important because, like I said, if your patient's on a heart monitor and he came in with, sinus tachy because he's anxious and he was out mowing the lawn and he was having, a cardiac issue, sinus tachy is one thing, but when things start to change, you need to be able to see where that difference is. So, and I'm not going to give you, heart complexes to learn. They're going to be very basic, but you'll be able to definitely see some sort of change that's like, oh, that's not right. So that's what 716 36-5 is all about. So definitely look all that up. All right, so let's see here, determination of the heart rate. If you look on 717, there's a determination of the heart rate. I put that on this slide here, but if you actually watch the YouTube videos that I posted, it's actually from a guy who I think teaches EMT class, but he breaks it down and makes it very easy and very logical. So I put this up here just for those of you who learn one way, and the YouTube videos for those who learn a different way. So, so definitely understand how this concept works. All right, so again, here's the rhythm analysis. It's the same thing. You're going to determine the heart rate. You're going to determine the heart rhythm, whether it's regular or irregular. You're going to analyze the actual P waves, whether or not they're present. Are they occurring regularly or irregularly? You're going to see if there's one P wave for every QRS, and you're going to determine if the P waves are smooth, rounded, upright, or inverted, because that tells you a lot about stuff too. So, all right, so let's see here. Along that same lines is going to be, you're going to measure the PR interval, you're going to measure the QRS duration, and interpret the rhythm itself. This sounds very, very complicated, but I can guarantee that once you watch those YouTube videos, it makes it really, really simple. So don't freak out, don't get all anxious, and don't have angina, for God's sakes. But like I said, if you watch the videos and as I explain things later, you'll definitely understand them. So, all right, so rhythms. We have normal sinus rhythm, we have dysrhythmias, we have tachycardia, bradycardia, atrial fibrillation, or AFib, we have ventricular tachycardia, or VTAC, and we have ventricular fibrillation, which is VFib. It sounds like a lot, but like I said, I'm going to show you some pictures, and you'll be like, okay, I understand what's normal, and now I see what's abnormal, and this is what it is based on memorization. So, all right, so this is tachycardia. This is, let's see if I can actually do this well enough. Point it out. I'll do red. All right, so there's your P wave, there's your QRS, and there's your T wave. Now, that's a normal sinus, or that's a normal heartbeat. Now, what makes it abnormal is the fact that this is going this fast. That's sinus tachycardia. Anything as far as a heartbeat over 100 beats per minute is tachycardia. We already knew that. But by looking at this rhythm strip, you're actually seeing that it's a heart beating. Atriums are contracting, ventricles are contracting, everything's relaxing the way it's supposed to. It's a normal heartbeat, it's just faster. Bradycardia is the same thing. You actually have a P wave, you have QRS, and you have a T wave. Same thing as the one before, it's just going slower. There's 1, 2, and 3. Whereas before, you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So it's faster, and this is slower. That's bradycardia. With AFib, you actually have a lot of P waves. That's your atrium quivering. You have a QRS, and there's your T. So with AFib, it's a heartbeat, but instead of the actual atrium contracting the blood into the vessel, the actual atrium is quivering and getting the blood into the ventricle, but not efficiently. So that's where the little squiggly line is. That's the P wave just kind of being very erratic. So that erratic wave is the electrical conduction system literally just firing away a lot, and that's just in the atrium. And then it squeezes into the actual ventricle. The ventricle sends it off to the lungs bring it back, and then everything else goes to where it's supposed to. With ventricular tachycardia, this is actually where the ventricle is beating so fast that it's not matching the lub-dub of the actual heart. So the atrium squeezes, it squeezes the blood into the actual ventricle, and instead of the ventricle squeezing and actually pushing it into the lungs itself, it's actually quivering very fast. And again, it's faster than the actual atrium is working. If they were working together very quickly, it's not great, but it's good in the sense that atrium contracts, ventricle contracts, atrium contracts, ventricle contracts. So it's squeezing the blood in and it's pumping the blood out, squeezing the blood in, pumping the blood out. Well, with ventricular tachycardia, the ventricle itself is beating way too fast, and the atrium's not able to keep up. Now, with ventricular fibrillation, this is actually where the ventricle itself is quivering, just like AFib. So instead of AFib and the atrium quivering, it's the ventricle that's actually quivering. So the atrium contracts, pushes the blood into the ventricle, but the ventricle actually doesn't contract efficiently enough to push it out. It literally just quivers. So hopefully that was easy enough. But again, once you actually watch the videos, it makes a little bit more sense. So for an assessment on page 731, 36-3, so let me get to 731. 36-3. All right, so care of the patient with dysrhythmias. I think this is actually very important because there's a lot of good tips. And one of the first things right off the bat, assess vital signs at least every 4 hours as needed. The reason why they do this is because based on the amount of cardiac medications we give them or status changes, your vitals are always the baseline of every assessment. So if you do them every 4 hours, you can see if there is a slight change from the morning to noon or noon to the afternoon, whether it be the medications or, again, things that are also happening. Can't tell you enough. especially working on the cardiac floor, always look at your patient first. If the telemonitor calls you and says, oh my gosh, your patient is a systole, which we all know is death, and you walk in the room and you run in there and the patient's in there watching TV and, you know, nice and pink and talking to you and alert and oriented, then obviously there's nothing wrong. But again, I can't stress enough that looking at your patient first will help determine if something is really truly going on. If they look good and they're pink and they're oxygenated and they're talking to you and everything is nice and calm, then you can go from there to actually prove whether or not you're looking at something that's correct, or maybe there's something wrong. But always look at your patient first. I can't tell you how many times that I've run into a room, you know, thinking that my patient's either dying or dead, and come to find out that he's sitting there watching TV. So always look at your patient first. Plus, to add to that, you know, you rush into the room and you're all anxious and you think there's something wrong, and all of a sudden your patient who was sitting there watching TV and is nice and calm is now going to react to you, which is now going to be anxiety driven because they think there's something wrong, and now their blood pressure and their pulse is going to go up. So walk in the room, be nice and calm, then assess them, because you want a baseline. You want to find out how they're doing and what they're doing, instead of blitzing the room and making them all crazy. So anyways, so what can I tell you? Dysrhythmias may be asymptomatic. I've had patients who have AFib that live with it and they don't even know that they even have it. Half the people in this room of 60 students, one of you may actually have some sort of heart condition that you may not even be aware of it, and you don't until you have symptoms and until something's checked out. So, and I'm only saying that just because, like I said, you're going to look at people, whether it be patients or people on the streets, and people just have things that are undiagnosed all the time. So, and I have patients that live with dysrhythmias all the time. Always assess the patient, obtain the patient's past and current history to find out where you're at. Always do a set of vitals. Your blood pressure and your pulse rate are going to tell you so much about your patients who have cardiac issues. The ECG or the EKG monitor is going to be much more definitive as far as exactly what is going on with the heart, and the psychological effect, which is anxious and fearful. You know, if you went to the hospital now and you have some sort of cardiac episode that may or may not be something that's very, you know, very frightening, and I hate to be that one that goes in the hospital and find out that, you know, you have something wrong and it needs to be fixed, and either one, it can't be fixed, or two, it may be a lot more detrimental than you want it to be. All right, so interventions, page 740. This chapter definitely jumps around. All right, so let's see here, 740, 36-5 and 36-6. So how to prevent or decrease dysrhythmias. So for the patient at risk for a vasovagal attack causing bradydysrhythmias, we'll go over vagal maneuvers in a bit. Patients with premature beats and ectopic rhythms, patients with ischemic heart disease, and a patient with risk of potassium imbalances. I think that I think we've talked about potassium to death between block 1 and block 2, but you should see some sort of pattern. The potassium is needed for pretty much every muscle in your entire body, and the heart is definitely a muscle. So whether we're giving them medications to correct a cardiovascular issue, whether or not we're giving them Lasix to actually pull the water off so their heart is able to beat better, a lot of this has to do with the potassium. So, I mean, you need to know your levels, you need to know what it's meant to do, and what being low on means and what being high means. So definitely learn that and understand it. For 36-6, there's a nursing focus on the older adult for the dysrhythmias. Again, this is really just kind of reiterating a lot of the of what the patient has and what you need to teach them, and get them back to either some sort of baseline or to be able to understand and live with what they're now being diagnosed with. I think that's pretty much about it. All right, so drugs. We give drugs for everything, and cardiovascular system is not any different. So if the heart's beating too fast, we'll give you a drug. If it's beating too slow, we'll give you a drug. And if the heart's not pumping correctly, we'll give you a drug. And if it's beating too poorly or fast or whatever, there's always a drug for something to correct what's wrong with your heart, and we'll go over those drugs later. Vagal maneuvers. I have a wonderful, interesting story about this. I had a patient about a year or so ago that was a bilateral BKA amputee. He was a severe diabetic that never controlled it. So that's how he lost his legs. And he was on the cardiac unit, I believe for some sort of other issue, but he had a history, an extensive history of cardiac disease and cardiac issues. So they put him on the tele floor for us to watch him just a little closer. And he used a wheelchair to get in and out of bed and to wheel up and down the hallways and stuff. And he actually went into the bathroom and he was constipated. So this is why I told you from block 1 until now, always be able, just make sure that your patient is able to and has pooped while they're in the hospital. And the reason why is because constipation can cause several issues, not just bowel issues, but other issues. So this gentleman had been in the hospital for about a week, and he was receiving, I wouldn't say a lot of pain meds, but just enough. And he went to the bathroom, or trying to, and he couldn't go. So he actually pushed and bared down so hard that he ended up having a syncopal episode, or passed out essentially, and he actually passed out and coded on the toilet. Now, bearing down that hard is called vagaling, and what it does is it actually it literally flattens out every blood vessel that you have because you're trying to push so hard. Now, it sounds extreme, but I mean, how many people have actually sat in the toilet where you pushed and you need to push and push and finally something comes? Well, just give it a little harder of a push, and that's called vagaling. And that's essentially what he did. He actually vagaled so hard that he literally cut off enough blood supply, and he passed out and coded. So I actually had to pick him up and take him back to the bed and do compressions on him, and unfortunately he didn't make it. Now, the reason why I know this had happened is because he was wearing a heart monitor, and the tele-tech called and said that there's something going wrong with his rhythm, and I needed to go check him out. So I walked in there and went to the bathroom, and that's where we found him. So anyways, but that's vagaling. You'll never forget that story, ever. Or the fact that your patient needs to poop. There's also interventions such as pacing. That's where they actually place either a pacemaker and helps your heart beat better or more efficiently through the conduction system. They have cardioversion, where we actually hook you up to a monitor and we synchronize it, and then we actually give you a shock to help reset your heart. Defibrillation, again, is pretty much the same thing. And then we have the radio frequency catheter ablation. If you have an electrical issue, whether it be your SA node or your AV node, they actually go through somewhat like a heart cath, and they go all the way up to where it is, and they actually either burn it or freeze it, and it causes it to die. And sometimes people can live without that they can live without one of their conduction points. So it's very interesting. All right, so for chapter 38, let's see here, where are we at? All right, so for heart failure, there are different types of heart failure. There's left-sided heart failure and right-sided heart failure. I do a little bit of high output failure, but you would just understand the concepts of heart failure or congestive heart failure overall. So with congestive heart failure, or heart failure itself, it's actually a ventricular problem. So we know it's a ventricle issue. It's usually the left ventricle first, and then both ventricles actually fail. In this chapter, I want you to be familiar with the ejection fraction. And the reason why is because as patients get older, or as heart disease worsens, the ventricles themselves actually change physiologically to the point where it doesn't allow the pressure and the blood flow itself to actually eject out of the heart as it once did. And as the ejection fraction lowers, the heart rate, or what's actually pushing out of the heart itself to supply the rest of the body, becomes less and less. I told you guys in block 1 that the first, in my opinion, the first organ and the most important organ to go first, based on lack of blood and nutrients and oxygen is really the kidneys. So the reason why I bring that up is because if your heart can't pump out enough blood efficiently, it's going to start to store in the thoracic cavity as much as it possibly can. So between your toes and your fingers and everything that's as far away from the heart, it's going to go first. But as far as organ-wise, your kidneys are going to be more affected than anything else. So let's see here. Let me draw a little picture. This is your heart. This is a right atrium, left atrium, right ventricle, left ventricle, which you know. Blood actually comes back in to the heart from the body. So this is unoxygenated blood. It goes into the atrium itself, into the ventricle, and out to the lungs. If this isn't working well, then the blood actually backs up to the rest of the body, and that's where you get the peripheral edemas. That's where you get all the issues that are from essentially, let's say, the neck down. If this isn't working correctly, then when the blood comes back into the heart, let's see if we can change this color. Okay. The blood is coming back into the heart from the lungs. This is oxygenated blood. If this isn't working well, then the actual blood backs into the actual lungs, and that's what causes pulmonary edema and the fluid overload of the lungs, because of the fact that it can't get the blood out efficiently enough. So I know, not the greatest picture in the world, but you knew that. All right, so left-sided versus right-sided heart failure. Left-sided heart failure is usually caused by hypertension, arterial disease, valvular disease, whether it be the mitral valve or the aortic valve. With right-sided heart failure, it's the right ventricle cannot completely empty. So the blood that's unoxygenated or deoxygenated is coming from the atrium into the right ventricle, and because it can't pump it out and empty out completely, that's what causes the actual ventricle to, because it is a muscle, the harder it has to work, the bigger it'll grow, but it doesn't grow as size of the heart itself. It actually causes the interior part of the heart where the ventricle is to actually grow inward, so it causes less space and less blood, and it doesn't actually allow it to give that kick or that squeezing motion to actually get the blood into the actual lungs. Cardiac output and stroke volume. So I think this is very interesting and probably a little important, I guess. So your cardiac output is the heart rate and the stroke volume. So the heart is actually beating, but the stroke volume itself is actually what is the extra kick that actually gets the blood out of the heart into the rest of the body. So your heart can beat 100 beats a minute, but if it can't efficiently squeeze all that blood out, then the cardiac output is poor. So again, I think that's important because, you know, you kind of, when you first start, you look at these heart rates and these blood pressures, you know, thinking, oh, everything looks really good, but essentially it looks good by machine, but internally the heart itself is not actually efficiently squeezing the blood out the way it really should. So remember, muscle gets tired, muscles get bigger, and the ventricles become dilated. And I think this is really important because I've said this especially with the respiratory modules, is that your patient that's breathing 30 breaths per minute, one, isn't necessarily getting oxygen where it needs to go, but your patient breathing that hard, that fast, for that long will eventually tire out and they will stop. And your heart's the same way. You have a heart rate of 110, you have a heart rate of 120, you have a heart rate of 150. It may be beating, but it's eventually going to get tired and it can't keep up and it can't do that for very long. So keep that in mind. So for left-sided heart failure, your assessment is going to be for the decreased cardiac output. You're going to have fatigue, you're going to have weakness, you have restlessness, dizziness, weak peripheral pulses, and pallor and cool extremities. And this kind of makes sense, right? So if the heart can't pump out oxygenated blood to where it needs to go, If you're not getting enough oxygen, you're going to get very tired. And being very tired is going to cause you to be very weak. With that, I think that definitely you're going to be dizzy because you're not getting enough oxygen to your brain. But you're going to get restless because something's wrong, you just don't feel right. Because of the fact that the heart is not pumping out the blood efficiently, it's going to cause whatever is the furthest away from your body, which we've always said a million times is your feet and your toes. Those peripheral pulses are going to be very weak. And because of the fact that it's not getting enough oxygenated good blood, it's going to cause the pallor and the coolness of the extremities. So that makes sense, right? So with pulmonary congestion, you're definitely going to get a hacking cough. You're going to have shortness of breath or breathless. You'll have some crackles and wheezes, and you're going to have the frothy pink-tinged sputum. You also have that increased respiration. So with the left-sided, if the actual blood coming back into the heart from the lungs is not working correctly, then it stands to reason that you're going to have fluid backing up, and that fluid is going to be the crackles and the wheezes. The frothy pink-tinged sputum is because, again, the lungs are filled with fluid. And then that hacking cough is just you trying to correct an issue. So you're going to try to cough up as much as you possibly can. And because of all the fluid and because of the hacking and all the coughing and everything else and stuff, you're going to be short of breath. So it makes pretty good sense, right? So for right-sided heart failure, you're going to have JVD, which is jugular vein distension. You're going to have anorexia. You're going to have nausea, edema in the legs and the scrotum. You're going to have distended abdomen. You're going to have polyuria at night. And you're going to have weight gain and increased blood pressure. And this makes sense because the right side of the actual heart, blood's actually coming in from the actual, from the body to be oxygenated. And because it's not working correctly and actually getting it to where it needs to go, it's going to back up. Now, once that once the blood backs up, it's going to have edema in the legs and the actual scrotum because it's the furthest part of the body, right? So with that happening, it's going to then start to push that blood and that fluid somewhere else. And that's where you start to get the distended abdomen. You're going to have the increased blood pressure. You're definitely going to have weight gain. And then because of all that stuff, you're actually going to have the nausea. And because of the nausea all the time, you're not going to want to eat, which is going to cause the anorexia. Now, the polyuria at night, this is actually because of the fact that you're laying down. And when you're laying down flat, and there's no gravity pulling on, whether it be your extremities or you standing up, whatever. Gravity is actually non-existent in the sense of you laying down flat. Everything's nicely evenly distributed. That's when your body is able to actually pull in the fluid back into the vascular system because it's at rest. And at that point, you're going to get up and you're going to pee all night long. Now, this is actually hard for guys because of the fact that for guys, if you're laying down flat and everything's evenly distributed and all of a sudden you start to pull in the fluid throughout the body into the vascular system, your kidneys are working fine and they actually start to work efficiently and you're actually having to urinate, we tend to get up in the middle of the night, we go to the bathroom and we stand to urinate. So if you're standing as a guy to go to the bathroom, that fluid shift from you being laying down and evenly distributed to standing up is going to cause a syncopal episode. And that's why most of the older gentlemen that you have, if they come in with black eyes and bloody foreheads and noses and stuff, and they've passed out in the middle of the night, it's because they got up to go to the bathroom. Guaranteed. Ask them, that's probably what happened. So, all right, so for psychosocial. Congestive heart failure or heart failure is a slow process. This did not happen overnight. It didn't happen yesterday. It didn't happen last week. This is an ongoing process that literally has gotten worse over time. So with congestive heart failure, this causes a lot of anxiety and a lot of frustration with your patients. It's going to be frustration with themselves because there's a lot of things that they used to be able to do and they can't do anymore. It's going to cause a lot of anxiety and depression with the family because they were once able to do a lot of things and now they can't. And that makes your patient feel bad. I've taken care of patients who are walkie-talkies and over time got worse, but their spouses stayed healthy and they still wanted to do things and they just couldn't because they're trying to take care of their sick one at home. Congestive congestive heart failure also causes shortness of breath. So for those who were able to do things that aren't able to do them before, it's because of the fact that they were short of breath. And again, it's just like the emphysema, the bronchitis, and the COPD. Those patients are not able to do a lot of things because of the exertion that it causes, and that causes their breathing to be short. This causes a lot of depression. So I mentioned to you guys before, understand and know the grief, the stages of grief, because again, these diseases didn't happen overnight. They were actually a process that happened over time, and people who used to be able to do things aren't able to do them anymore, and that causes a lot of psychological issues that that they need help with. So, all right, so I mentioned before labs. So things you guys actually need to think about, or at least understand, memorize, learn. You're already tested on them, so you might as well get used to it. Electrolyte imbalances, you need to know the side effects of drug therapy, which we'll go over in class with over the drugs, and what the labs look like. So I mentioned before the CKMBs, the troponins, your potassium levels. I think there was a couple other that I might actually wrote down. There's a BNP. You need to know your PTs, your PT9Rs, your APTTs for your heparins. Know your labs, because those are going to tell you a lot about either the intervention you're going to do, what you can't do, and how your body's reacting to certain things. The BNP is actually, with shortness of breath, it tends to throw out, or actually I take that back. With BNP, it's actually the fluid buildup that actually tells there's an effect with your bloodstream that actually tells you that there's something wrong with the heart and the lungs itself. Also, you can do urinalysis and microalbuminuria. This is an indication of heart failure. And then you also have your ABGs. And that actually, ABGs will tell you whether or not your patient may be shortness of breath, and if they're alkalotic or acidotic, whether it's a respiratory issue or a kidney issue, and we've talked about that before. But with ABGs, this also tells you that if your patient is shortness of breath and not getting enough oxygen into their bloodstream, it could be a cardiac issue. Because again, as mentioned before in class, that it's not just a matter of you taking care of someone with a respiratory issue and also a cardiac issue. You're really taking care of somebody who has a multiple organ dysfunction, and one leads to the other, or one actually affects the other. So keep that in mind when you actually are looking these over and kind of studying, because again, it's not just one system for each problem. So with images, you have chest X-ray. This will actually show you an enlarged heart, hypertrophy, or dilation. The radionucleotide study, this actually shows the left ventricle ejection fraction. And again, you want to be able to see whether or not they're efficiently pushing and squeezing the blood out of the ventricles and into the rest of the body. And again, you have the ECG or the EKG. So for nursing diagnosis or goals, you have improved gas exchange, you have improved cardiac output, you have decreased fatigue and weakness, and you want to prevent or manage pulmonary edema. So on page 755, let's see here, go back 10 pages, and you have 37-3. Key features of pulmonary edema: acidic crackles, shortness of breath at rest, disorientation or acute confusion. You have tachycardia, you have hypertension or hypotension, you have reduced urinary output, cough with frothy pink tinted sputum, which we mentioned before, premature ventricular contractions. So instead of the atrium and the ventricle, squeezing at the same time, the atrium is actually getting ready to squeeze, and the ventricle beats it to it. So you also have anxiety, restlessness, and lethargy. So again, it's probably because you're actually not getting enough oxygen to the rest of the body. And that causes the shortness of breath, causes the anxiety because they can't breathe real well, and it makes them really tired. So interventions, again, here's drug therapy. There's a million cardiac meds that will cure whatever ails you. You're going to apply administration of O2 so they can actually breathe better, or at least get enough oxygen for their body. You'll do a set of vitals to make sure you have a baseline or see if there's anything different from the original baseline. You'll have cardiac resynchronization therapy, which is, again, that's when you do the defibrillations or the cardioversions. You have ventricular assisted devices, or you have heart reduction therapy. Again, your heart's a muscle, so actually over time your heart muscle will get bigger, but it gets bigger on the inside. So a lot of times they'll actually go in and they'll do some cauterization, or they'll actually do some cutting to where they can make the heart a little bit bigger on the inside, so it actually will hold more and squeeze better. Let's see here, I can't tell you enough, between the COPD patients and the congestive heart failure patients, we need to keep them out of the hospital. And one way of doing this is to come up with some sort of community-based care or home care, or teaching them how to care for themselves. So with community-based care, these are clinics or clubs or things for people who have congestive heart failure or cardiac issues to be able to go and be around other people who also have these issues, and be taught by people who are trained to teach them about their meds and teach them how to live as well as they possibly can, and give them the support they actually need. With home care, again, you can actually have nurses come and visit and stuff, but you wanted to actually teach them about their own self-management and their own care at home, so it keeps them out of the hospital. And again, you have to find out what your patient's literacy level is, find out what they actually understand and what they can absorb, and teach them and have them teach back to you that they actually do understand what's going on, and teach them about their meds and how often and what they are and what they do, so that way they can continue living outside of the hospital. Alright, so here we go on to hypertension. So normal blood pressure is 120/80, and hypertension is anything over that, but specifically 140/90. So page 776 is let's see here, 776, 38-3. So for blood pressure clarification, you have the normal, which is 120/80. Prehypertension is 120 to 139 systolically, or 80 to 89 for diastolically. You have stage 1 hypertension and stage 2 hypertension, which is the 140/90, or a systolic blood pressure over 160, or diastolic over 100. So kind of know those and be familiar with the difference between normal, prehypertension, and hypertension itself. So hypertension, the causes can be family history, being African American, having hyperlipids or an increase in lipidemia. It could be smoking. It could be age-related. It could be too much sodium or too much caffeine in your diet. It could be increased weight, stress. And then in the book, it actually mentions men versus women, in the sense that I think men tend to have lower blood pressure than women, but then as the two age groups increase with age, so does their blood pressure. And I think women tend to be better in the long run, where the men tend to have higher blood pressures. So for your assessment, you're going to assess for the risk factors, which again is going back to all the primary causes of hypertension. And then you're going to ask about hypertensive crises, which is on 784, box 38-2. So emergency care for patients with hypertensive emergency crisis. This is going to, you're going to assess for severe headaches, extreme high blood pressure, dizziness, blurred vision, shortness of breath, nosebleed, and severe anxiety. This is, going back to the other box that actually has the hypertension, the prehypertension, and the normal blood pressures. This is getting to the point where your blood pressure's, well above 200/100, and because the blood pressure is so extremely high, it's starting to affect the capillaries of almost everything. That's why you get the nosebleeds. That's why you get the severe headaches and the severe eye pain. My grandfather used to have high blood pressure to the point where he would have nosebleeds all the time, and that was one of the first indications of that his medication, his blood pressure medication, wasn't working well enough. Also, I've had a friend who is Italian. He was a short, little, stocky guy, and his blood pressure would actually get pretty high, and it would get high enough to where he actually could feel the pulse in his ears. So that was his little hypertensive crisis. So again, you're going to ask about headaches, dizziness, and the fainting because the blood pressure is so high. You're going to do a set of vitals. Again, you're always going to check for baseline first, and do the vitals to make sure that you're proving what you're seeing. You also do something called orthostatics, which is you do a set of vitals while they're laying down, another set while they're sitting up, and then do another set while they're standing. And if you actually have a difference in blood pressures systolically and diastolically by 20 millimeter mercury or 10 millimeter mercury, then there's a problem with the blood pressure as far as going down or dropping or increasing while they're actually doing activity, and the changes of statuses. So interventions, you're going to teach the patient about lifestyle changes, whether it be losing their weight, restricting the amount of sodium they actually consume in their diet, controlling the amount of alcohol they actually drink, learning how to exercise, relaxation techniques such as yoga or meditation, and definitely have them stop smoking and caffeine. The smoking and the caffeine are vasoconstrictors, and that causes your blood pressure to go up. And with the sodium, the more sodium you consume, the more water follows sodium, and that causes more water retention, and that retention is what causes the blood pressure to go up. So again, with drug therapy, you can have hypertensive drugs and also diuretics to pull that fluid off of, or fluid out of the vascular system. So next, we're going to do peripheral arterial disease. This is disorders that change the natural flow of blood through the arteries and the veins, and usually in the legs. The causes are usually atherosclerosis, and it's a blockage of the arteries with plaque causing the lack of oxygen and nutrients. So the stages of peripheral artery disease is on 786, 38-3. Key features of peripheral arterial disease is no claudication is present. You have the bruit or the aneurysm that may be present. You have the pedal pulses that are decreased or absent. Again, it's because the actual blood flow itself is very poor. With stage 2, you have claudication. This is muscle pain, cramping, or burning, which occurs with exercise and is relieved with rest. Symptoms are usually reproducible with exercise. Stage 3 is rest with pain. Pain while resting commonly awakens the patient at night. So if those patients that actually wake up in the middle of the night, which what they think is a Charlie horse, it's usually the stage 3 stage. Pain usually occurs in the distal portion of the extremities, such as the toes, arch, the forefoot, or the heel, and rarely in the calf and the ankle. And you also have stage 4, which is necrosis or gangrene, which is the picture on 787. So again, peripheral artery disease, you have resting pain, you have numbness and burning, usually found in the toes, feet, or heels, and the calves or the ankles. So with inflow disease, you have pain in the low back, the butt, and the thighs. This causes the patient to stop walking. And that makes sense, right? So if you're actually walking around, you start having a lot of pain, and it's higher up and affecting your back and your legs, then you really stop walking, and that lack of exercise causes you to gain some weight, and which causes more pain because of the weight itself. So with outflow disease, it's the burning and cramping of the calves, the ankles, the feet, and the toes, and this may be relieved by rest. So symptoms of peripheral artery disease is hair loss on the lower calf, ankle, or feet. You have dry, scaly, dusky, pale, or molten skin, and you have thickened nails. And again, this is based on being some sort of partial occlusion that's causing the blood flow, the oxygenation, the nutrients to not be as good as it once was. With severe arterial disease, the extremities are cold, cyanotic, darkened, and they have muscle atrophy. And again, that makes sense, right? If you have a non-occlusive blockage, but enough that it's really slowing down that arterial blood flow, you're going to have the cold and the cyanotic darkened feet because of the lack of oxygen and nutrients in blood supply. So for imaging, you're going to do an arteriograph, and this is looking for the narrowing of the arteries and an actual occlusion. So peripheral artery disease interventions, you're going to palpate pulses in both legs. You're going to make sure that they're able to get, that they're getting some sort of blood flow. You're going to assess for ulcers, especially in the toes, because of the lack of oxygen and nutrients and blood supply. Then you start to get breakdown, and with that breakdown tends to be the ulcers that just don't heal. You're going to teach the patient about intermittent claudication. And with peripheral arterial disease, again, this is arterial, so how do we get the blood flow to travel further down the leg? What you can do is going to be exercise, elevate the feet. You're going to sit in a chair instead of laying in bed, so that way the gravity actually pulls as much as it possibly can in arterial blood to the extremities. You're going to promote vasodilation by providing warmth, but not obviously directly because of the lack of blood supply. They tend to have not as good a feeling in the extremities. So applying something that's too hot, they don't know that it's too hot, and it can actually cause burns. You're going to reduce the exposure to cold because cold obviously constricts. So if it constricts the blood vessels, then it's doing the opposite of what you want it to do. Again, smoking and caffeine are vasoconstrictors, so doing that makes the blood supply even less. So you want to cut those out. And obviously drug therapy can help too. For invasive interventions for peripheral arterial disease, you can do the arterial revascularization. That's actually where they go in and they either strip the vein or the artery, or they actually put in stents or do something to make the arterial blood supply go, and that could be really just as simple as fixing the vein or the artery itself. You also do a bypass where they actually take out the vein, I keep saying vein, where they actually take out the artery and put in a new one, or they actually bypass the artery altogether and surgically reroute the blood supply. You also could do a thrombectomy. If there's some sort of thrombus that's occluding that artery, then they can actually go in and remove that thrombus itself. So again, home care on 791. Let's see here, 38-5, the patient with peripheral vascular disease. As far as home care, again, you want to keep these patients out of the hospital. So the more you can teach them, the more they can understand, the more they're able to do their own interventions at home and prolong the process of the disease getting worse. For foot care, you have the same page 791 and 38-6. Keep your feet clean by washing them with soap and water. Keep your feet dry. Definitely avoid injuries so you don't get the ulcers. Keep your toenails clean and filed. It says here to have someone else cut them if you cannot see them clearly. That's fine, but make sure that they know how to cut them correctly, because again, if you cut them too short or you actually nick the skin, you're actually going to cause ulcers. You want to prevent them from being dry and cracked, because again, those will cause sores or breakdown. Let's see here, I've already mentioned about preventing exposure to the extreme heat or cold. Avoid constricting garments, because obviously you're constricting more of the blood flow. Avoid extended pressure on your feet or ankles. Again, this really just kind of puts more pressure on them, which could actually either cause breakdown. So, arterial occlusions. This could be an embolus. This is a blood clot that travels. Symptoms of that will be a pain, pallor, pulseless, paresthesia, paralysis, and I have no idea what poikilothermic is. But those are a lot of P's. But that makes sense, right? An arterial occlusion, there's an occlusion in the artery, and wherever it is going to be stopping the blood flow, the oxygen, the nutrients, which is going to cause pain. The arterial blood's not going to be going as far as it needs to go, which causes the pallor, which is that that pale kind of maybe dusky skin. The pulse will either be weak or lacking altogether, which will cause numbness and tingling, or even no feeling at all. And obviously it's going to be cool because there's not enough blood supply. Interventions could be anticoagulant therapy. It could be your Coumadins and your Levinoxes and your aspirins and your Plavixes and all those other things. You could do a thrombectomy or an embolotic ectomy. You could do pain meds because of actual the pain. And you can also assess the pulses to make sure that it's not completely occluded. If you check the pulses and there aren't any, and you actually have, pale gray feet that are cold, then obviously that's a bigger issue. There's no blood supply to those feet at all. Peripheral venous disease, or PVD, the veins are not operating properly. This is deoxygenated blood that is not returning back to the heart. This could be because of an actual thrombus or a deep vein thrombosis. This could be caused by varicose veins, which is a defective valve, or it could be defective skeletal muscles. Again, the more we walk, the more we actually use our legs and move, the muscles themselves will actually help constrict around veins and arteries and helps push the blood supply. If those aren't working correctly, then you're not actually having anything help move that blood a little bit better. Causes for DVTs could be hip therapy, total knee replacement, prostate surgery, ulcer of colitis, heart failure, cancer, oral contraceptives, or the inability to actually move. Health promotion for DVTs is to avoid oral contraceptives, drink plenty of fluids, exercise daily, especially the legs, and patient education. I think that drinking plenty of fluids is probably the easiest, best thing you could do, based on the fact that the more fluids you drink, the more hydrated you are. The more hydrated you are, the more it dilates your blood vessels. It also thins out your blood naturally, so you're able to actually move as much blood as you possibly can, as quickly as you possibly can. If you have a deep vein thrombosis or some sort of occlusion, you want to make it as easy as possible for the blood to flow. So for your assessment, you're going to have calf or groin pain, you'll have swelling, you'll have the positive Fohmann sign, which I was taught in school, but according to some of the research, and I think even the book says this too, that the Fohmann sign has actually not been proven, so believe what you want. You have to compare the legs. If you actually find that one is bigger than the other, then that's probably the more effective leg. And if you find that there's calf pain and there's swelling and there's warmth and edema and redness in one leg as opposed to the other, you're pretty safe to say that you have a blood clot. But you're also going to do diagnostic testing. So you're going to assess them by both legs. You're going to do an ultrasound or a Doppler to find out if there is in fact a thrombosis and where it is. You could do an MRI, and then we mentioned this before, the D-dimer is a test that you do. Blood clots throw off a protein, and that protein is found in the blood. So if that protein level is high enough, it'll show up on the D-dimer lab result, and the higher it is, the more likelihood that you actually have a blood clot. Interventions are going to be rest. You're going to elevate the legs. Do not massage them because you could break off the actual clot. You're going to apply warmth so that way you can actually vasodilate, which you do have. You're going to do warm soaks because, again, the warm heat is going to actually cause vasodilation. And then you also have drug therapy, which is the anticoagulants. On page 801, let's see here, 801, 38-7, patient receiving anticoagulant therapy. So here's a lot of good information on what to do for patients who are on the Plavix and the Levinox and the Coumadins and the aspirin therapies and stuff. So definitely understand, and what I'm quickly scanning over, I would be safe to say these are a lot of good test questions. See here, know the labs. So I mentioned the labs before. You definitely want to know your INRs, your PTTs. You want to know your PTs. So definitely know them, what their values are, and what they're meant to test for. So for interventions of a DVT, surgical management could be a thrombectomy, and then 804. Let's see here. 38-9, which is the venous insufficiency. You have the graduated compression stockings, and you have the do's and don'ts of what to do for venous insufficiency, which is actually pretty good. That seems to be it. So unfortunately, this is an hour and 14 seconds long. I know we talked a lot. I know there's a lot of information. I know there's a lot of things where I just kind of threw boxes at you and stuff. But again, I think if you actually read the chapters, read what I've actually told you that I thought was important, check out the 2 websites for the acute myocardial infarction and the angina pain. I think that it's a lot, but I think it's manageable, and I also think that if you really keep an open mind and kind of logically think things through, it will make a lot of sense. Perfect example, you have a DVT, you have a blood clot in your leg, you are getting some blood supply, but not a lot. It does hurt, and it's actually swelling, and the pulses are getting weaker. Applying something as simple as heat just helps dilate. Drinking plenty of fluids. I can't tell you enough that how much smoking and caffeine actually really affects the blood supply in the heart, the veins, and the constrictions and all that stuff. So again, when you read these things, as far as sticking with the symptoms, the interventions, and what you're hoping to accomplish, I think you'll be pretty good on the test. So if you have any questions, bring them to class. And I think that is pretty much about it. So definitely check out the other videos for the dysrhythmias, so you have a better understanding of it, and we will go from there.